طيب بسم الله الرحمن الرحيم بسم الله الرحمن الرحيم وبه نستعين والصلاة والسلام على أشرف المرسلين سيدنا وحبيبنا ونبينا محمد. As you know, mammogram is a gold standard method of breast imaging, and بفضل الله تعالى وحمده we complete the course of mammography, and today we are going to start high resolution breast ultrasound. And as you know, it is a second chair in orchestra of diagnostic breast imaging tools, and along with mammography representing the conventional modalities is complementary both for mammography as well as for breast MRI. Ultrasound has been playing an increasing important role, representing an additional diagnostic tool, raises the detection rate of breast cancer as well as benign breast lesions. Okay. The learning objectives of our breast ultrasound course is to discuss the following. Would like to understand by the end of the course what is breast ultrasound, how to do breast ultrasound regarding including proper equipment, describe ultrasound technique and technical considerations for optimizing breast sonography. Also, we want to know what is normal on ultrasound, what is the sonographic anatomy and breast ultrasound terminology, when to do breast ultrasound, the indications, and how to read breast ultrasound using ultrasound ACR lexicons for image interpretations, including features of benign as well as malignancy, and what are the fears and pitfalls of breast ultrasound, what is elastography, breast ultrasound state of art, how breast ultrasound supplement the interventional procedures, and how to use ultrasound in management of breast clinical problem using a case discussion or case examples. And today we are going to start with the introduction and by how to do breast ultrasound, discussing image quality issues and technique for image optimization, including selection of proper equipment. So what is breast ultrasound? Breast ultrasound is the use of medical ultrasound or ultrasonography to perform imaging of the breast, having the same concepts of medical ultrasounds, okay, using the same machines, and it started about 5 decades earlier, as long as mammography. And the first clinical use of breast ultrasound was reported 1951 by Wild and Neal, okay, and thereafter subsequent mode of development for breast ultrasound occur, and you can see here this is earlier breast ultrasound, a grayscale image in 1970s. Can you imagine this crude image? In this crude image, this is a cyst, and compare it with high resolution current, very beautiful imaging delineating a simple cyst. So confidently here we can say this is a benign lesion, no need to put a needle and to take a biopsy. And with advances in ultrasound technology, the role of ultrasound has been extended not only to differentiate cystic from solid, but further characterizing the soft tissue masses to differentiate benign from malignant masses, and describing the cysts further, differentiated symbols, septated clusters of cysts, and what is inside the ducts, okay, and further delineating the normal anatomy of the breast to the level of terminal duct lobular unit as seen in this image. And the continuous advances in ultrasound technology of higher frequency transducer as well as improved device software result in possible highlight fine structures like microcalcifications, as you have seen in this case. Look for these small lesions and associated microcalcification in a case of lobular carcinoma with associated DCIS in the upper outer right breast was not seen on the mammographic, the associated mammography study. And to the era of 3D ultrasound, the development being extended. Okay. As with all imaging modalities, the value of ultrasound for detection and diagnosis is largely depends on the quality of the images. An appropriate technique is crucial to achieve accurate lesion characterization. And this is emphasized in the second edition of the American College of Radiology, ACR latest edition 2013. So, first of all, to have good image quality, we'll start from the machine selections. Which ultrasound equipment features are beneficial for breast ultrasonography? Okay. The ACR practice guideline for performance of breast ultrasound examination 2011, they recommend the use of real-time handheld transducer with high resolution linear array broadbands widths with a center frequency of at least 10 megahertz at the high frequency end between 12 and 18 megahertz in their lower frequency tissue penetration of 5 centimeter obtainable. And the current generation ultrasound machines offer additional image processing facilities, including higher resolution multi-frequency transducer, harmonic imaging, compound imaging, Doppler speed of sound imaging, we mentioned the high resolution transducer, elastography, and 3D ultrasound of the breast. These are more recent. Almost all of these technologies are available in modern unit and are optionals, and we have to make use of it to help in improving ultrasound image. So starting by the transducer, breast ultrasound should have excellent spatial and contrast resolutions. And the broadband high frequency linear electronically focused probe currently offer the best combination of both excellent spatial as well as contrast resolution for breast ultrasound up to 0.1 millimeter resolutions. And the high resolution broadband width linear transducer available are 12.5, 17.5, and currently there is also 18.5. Okay, and the latest this is now is recommended to be used, and because they the studies, or one of the study showed that most of the breast with optimizing positioning, okay, it will be compressed to the maximum depth of 3 centimeters. So it will not be more superficial for the depth of most of the breast. Ideally, a wide footprint probe is recommended, and they recommend the available is 38 millimeter or 3.5 centimeter and 5 centimeter footprint. They don't recommend the 6 centimeter. They said that it will be large, and the edge of the probe, it will not be in contact with the breast. It's okay. May I ask you questions? Can you tell me this image, okay, which one with 17.5 and which one with 12.5 linear transducer? It is the same lesions, okay? Same breast, same lesions, when examined with each transducer. May you tell me which transducer for each image? The left?
The left is 17.
This is the left and this is the right, huh?
17. 17, the left.
This is the 17 and this is
Right,
why? Why?
The depth, because 17 is more superficial than 12.5.
So because the lesion is just beyond the skin, so it needs a higher resolution transducer to give more details, and the 17 is higher frequency. It has to give the better resolution. In this case, if you look here, this is yes, you are right, this is 12.5 megahertz transducer. It looks like as if it is questionable. Is it a fat lobule or rear lesions or what? But by using a higher frequency probe, it is clearly here probably benign lesions look like fibroadenoma, and it was stable on follow-up. Though the usually the commonly used for the breast or for the average breast is 12.5 megahertz. Okay, if you don't have the 17.5 megahertz, how you can approach or you can improve the visualization of these superficial lesions?
By putting pads, applying pads.
What, hint? You are right.
Applying pads to see more superficial.
Applying what?
Pads.
Pad of gel, yes. About 1 centimeter or so, okay, pad of gels. It will add more depth for the lesions, and we can use it to see the most superficial one. Yes, yes. The commonly used we said is 12.5, but we can use stand-off pad of large globe of gel to visualize the most superficial lesions with relatively less frequent frequency probe. Okay, and usually the depth. What is the depth of transducer of each transducer? Up to. Okay, we'll discuss later. No problem. Okay, regarding the image selections, as we described, okay, we said in the previous examples, the higher frequency, okay, will be good for more superficial lesions, but the breast will attenuate the sound, and the deeper structures might not be visualized by this higher frequency. And as we described for the recent or modern ultrasound breast, the linear broad bandwidth transducer enable us to scan with a high resolution in superficial tissue without compromise of penetration deeper to field of view up to 5 centimeters. up to 5 centimeter depth. Yani you will see 5 centimeter depth. This is with 5 centimeter if you use the 12.5 megahertz. But if you use 17.5 or 18.5, you will see up to 3 centimeter depth. See?
Okay.
It will be difficult to visualize beyond that. But yani, rarely we might have a huge breast, large breast, or sometimes the axilla, the more deep structures, okay, in the axilla. Or sometimes there is some inflammation also attenuate the sound. So sometimes we might need to use a lower frequency transducers, okay? And sometimes even we might need to use the convex or the curved transducer. As you have seen here, this is in the axilla, okay? These malignant lymph nodes are so deep in the axilla, this is my case, difficult to be visualized by the linear transducer. I use the curved transducer to visualize deep into the axilla. Also, this is my patients. You see, this is large lesions and attenuating the sound. I could not evaluate the deep margins of the lesions. Even I use a trapezoid extended field of view. So when I used the curved array, I could visualize the whole lesions and I could measure it well. And I'm not losing even the margin characteristic of the lesions. This is another example here. Heavily shadowing lesions. I could not evaluate and see the deep portions, the extent of the lesions when I use the curved low frequency transducer. I could see the whole lesions and without losing its characters, its suspicious features, and I could measure it. Okay, so to understand something about the resolutions, okay, especially the spatial resolutions of the transducer have long axis and have short axis or elevation plane, okay? And usually the long axis, okay, can be electronically focused. However, the short axis is usually fixed for each probe, okay? And these are affecting the lateral resolutions. And we'll see together what is the lateral resolution. But with within the modern ultrasound machines, there is something what is called matrix probe. Malaz is going to tell us about it more than me, okay? And this matrix probe having a facilities, okay, to focus also in a short axis or in elevation plane, which is usually fixed for each probe, okay? And this is why, because the too deep focus, okay, or too deep structure or lesions, it will cause volume averaging artifacts, okay, with the high frequency transducer. We'll see here. And so also we have to optimize the focal zone for the lateral resolutions. This is the elevation planes with what we said it is fixed for each transducer. And you see, for this, as we mentioned before, we set 3 centimeters, and it is for this transducer here, okay, it is about 1.5 centimeters, while for the low frequency, it is a little bit deep for about 3 centimeters. What does it mean? This is the narrow beam. Look for the narrow beam. And the area of the maximum narrowing. You see here the maximum narrowing, it will be about 1.5, and the area of maximum narrowing, you see the lesion, it will be sharply delineated. You can see the lesion sharply delineated, but if it is not at the narrowest part of the beam, high or low, okay, so like this, it will affect the lateral resolutions, and this part will give a volume averaging, and this volume averaging will affect the margins of the lesion as well as the content of the lesion itself. If you have a cyst, if you see it here, definitely the cyst, it will be sharply demarcated, okay, and you will see it as equiluscent structures. But if it is fall here within these regions, you will see the cyst as might be hypoechoic, looking like a soft tissue lesions, okay, or it might be completely misinterpreted. Is it clear? So
Yes.
with a higher frequency transducer, that is why the higher frequency transducer is better for imaging lesion closer, okay, to the skin, because the narrow zone or the narrower beam width, it will be more close to the skin, okay? So it will improve, this will improve differentiation between a subtle shade of gray and the margin resolution, as well as lesion conspicuity in background of fatty parenchyma. Okay, also to improve this, we call it lateral resolution. What we discussed, this is a lateral resolution regarding the depth. Also, this can be affected by optimizing the focal zone. You know, in ultrasound machine, there is a cursor, okay, or there is a button. You have to move it and fix what is called a focal zone. Okay, this will affect the lateral resolution, even with a high frequency matrix probe. Also, we have to optimize the focal zones. It indicated by moving arrow head at the side of the screen. We'll see as here. Look for this one. This is the focal zone far away from the cyst. Look for the cyst. It seems as if it is a soft tissue with the focal zone at the level of the cyst or the middle of the lesions. Then it will optimize image and giving a better characterization of real cystic structures. So when surveying the breast, the focal zone, it should be placed at the mammary zone, at the middle between the skin and the pectoralis muscles, to visualize, to give overview. But when a lesion is identified, then we have to place it at the center of the lesion to have an optimum lateral resolutions. If you have 3 focal zones and sometimes 2 focal zones, also we can adjust it accordingly. The effect, this is the focal zones. When you put the cursor like this, then that means you put the lesion at the narrow, okay, the narrower part of the beam. That is why we will optimize, okay, the margin resolution or the lateral resolutions. We'll see better the margins and better the component or textures of the lesions. Right. The effect of ultrasound focusing, the focal zone indicated by white appropriate in the left plane showing anechoic. This is the same what we discussed, okay? This is another example here. Look for this image, how it is blurred and structureless, okay? we can see nothing because the focal zones was not appropriately placed. You see, look, the focal zones here is far from the area of interest. It is at the back of the image, even below the pectoralis muscles. So that is why everything is blurred and we can see nothing. When the focal zone is adjusted, look how the image demonstrates all these details. Okay. Regarding equipment selections, we need to have a wide field of view for a single sweep. Okay. So what is the a wide field of view? Do you know it? Mm-hmm. This is what we call it a panoramic view. Okay, the panoramic view, the extended field of view, also we call it a panoramic view. You will use the machines, you press a button and you sweep throughout the area of interest like this. Okay, giving a single image for a larger area extending beyond the footprint. If the footprint is 5 centimeters, this area might extend up to 10 centimeters continuously. We call it a panoramic view or extended field of view. It is an option, you see, and it is helpful, especially in case of multifocal and multicentric disease. You can measure large lesions or measures collectively multifocal lesions within a same quadrant or within a 5 centimeter area, or measure the distance between the lesion to decide is it a multifocal or multicentric if it is more than 5 centimeters, you see. And you can also, okay, evaluate the lesions in relation to the other structures, like in relation to the nipples and so forth. This is here, this is my patients, this is a panoramic view. Look for the lesions is larger than the footprint, that is we could, and this is here, look for these lesions. In this image, we can see one of the lesion. In the other image, we could see when you can use it in transverse and in longitudinal. When you change to perpendicular view, you can see more than one lesion. This is one way or one method of extended field of view. There is another method for extended field of view to divide the screen into two parts. You will take the image, this part, and you fix it, or and then open the second field of view and take the rest of the lesions. Look here, this is the duct, but if you can see, these are two screens, okay, or two views. The rest, look for the rest of the ducts. There is a soft tissue here in a case of a cancer related to a duct. We call it a banded image, okay? Not like that when the one image panoramic view or the previous extended field of view. There is also, what is the difference between these three images? This is the usual rectangular, okay, of the image of the linear transducer, and this panoramic view, extended field of view. What about this one? This we call it a trapezoid imaging, okay? The field of view is widened in the far zone. Also, this a trapezoid image, and here this is a trapezoid image. It looks like same like the sector or the convex probe, but it is not a convex probe. It is a linear probe, but there is a facility to widen the far zone. Okay, widen the base of the image, give a trapezoid, a triangular like image like the convex probe image. Okay, so these are 3 ways of extended field of view, and ultrasound, most of ultrasound machines having the facilities of the 3 or having facility of some of which. But currently, okay, the 3D with 14 to 15 centimeter footprint enable a broad sweep of tissue displayed in 3-dimensional ultrasound. Okay, we need a Doppler. What is the importance of Doppler for breast ultrasound? Do you think it is important, or how it is important for you?
Yes, it can differentiate some lesions from others. And for example, if we have a cyst and inside it there is a soft tissue component.
Excellent.
With the
Excellent.
Doppler, we can,
yeah,
yes,
help
differentiate it with the
help in evaluation of complex cyst. Okay, cyst. Excellent. Well done. What else?
Also inside the ducts, the same concept inside the ducts. If we have a
yes, intraductal lesions. Excellent, well done. Helpful in intraductal lesions. What else?
Helpful in
What?
hello in the axillary lymph node if it
Axillary
is
lymph node. Excellent, well done. Okay. What else?
Mastitis and inflammatory processes in the breast.
Excellent.
Vascularity of a suspicious lesion. Vascularity of a suspicious lesion. To see the vascularity of a suspicious lesion.
Yes. It is Doppler is complementary to the grayscale. Okay, and current ultrasound lexicon, they recommend evaluation of lesion vascularity, but not as a mandatory, as optional, as a complementary to the grayscale. Okay, because why? Because there is substantial overlap between benign and malignant features. But before going to characterizing these type of lesions, what important technical issue while doing Doppler, we should not press hard. The transducer should be lightly, okay, pressing into the lesion so as not to occlude the vessels. Otherwise, you might see or you might not detect vascularity. If you press, you press hard. Okay, this is one technical issue. Regarding the differentiation between benign and malignant, as we mentioned, there are overlap, but in general, more the malignant lesions demonstrates more vascularity with penetrable or penetrating vessels having a liaison. We'll see it in the interpretations part of the ultrasound, but the pattern of vascularity a little bit more suspicious than in the benign natures, which are usually peripheral, double vascular veins. When we find veins and arteries, separable vein and artery, and at the periphery of the lesions, not within the center of the lesions, more in favor of benignity. While usually with malignant, the vessels are irregular, branching, giving a liaising artifact, penetrating the lesions, going inside the lesions, and all these features more in favor of malignancy. But as we mentioned, not very precisely differentiating between the benignity and malignancy. But definitely Doppler is helpful, especially in intraductal lesion, if it is present. If it is not present, it will not exclude. But if it is present, definitely it will preclude that it is to be in specific secretions, and it's useful in evaluation of scars, complicated cyst or complex cyst, and in case of lymph nodes. Okay, these are examples of a duct, okay, demonstrating intraductal vascular echoes. That means these definitely are not in specific secretions. These are soft tissue. We have to go further to exclude or to give a pathological diagnosis for these soft tissue. In these both cases were a papilloma, while in this complex cyst there is a soft tissue component with the feeding vessels here. Okay, we cannot decide before Doppler. And also in this case, this is an inflammatory cyst, complex or complicated cyst with peripheral vascularity, similar lesion here. It is high-grade invasive cancer with intra-lesion vascularity. So differentiate between these two lesions. This is invasive cancer and this is inflammatory cyst. And also this heavily vascular high-grade lesions appear as anechoic lesions, like cystic lesions. Presence of vascularity, especially in high-grade cancer, differentiate cyst from soft tissue malignant lesions, and also the metastatic lymph nodes. Even if it is not deeply hypocystic, the presence of cortical vascularity is definitely a suspicious findings on lymph nodes. And Doppler also helpful in post-therapy evaluations. Look for these lesions, the vascularity, how it reduced after treatment. And in this case of calcification seen here on mammography, and this is grayscale ultrasound, on Doppler ultrasound demonstrate what is called as twinkles artifact. This artifact is mixture of red and blue color. It is usually occur behind strong specular reflectors like calcification and biopsy clips. Okay. What about this image?
This ultrasound elastography.
What is this? Excellent. So here, yes?
Yes, this is ultrasound elastography.
Yes, this is elastography. This is a grayscale, and this elastography image. Okay, this is elastography. Okay.
The red.
What is elastography, as here?
Elastography.
The concept of elastography.
It means measurement of pressure or the elasticity or stiffness of the lesion by two mechanisms, either pressure, could called strain, or shear wave elastography.
Excellent, excellent, excellent. Well done. Okay, so elastography, it is the same concept of palpation on clinical evaluation. When you palpate a malignant lesion, you will feel it as harder compared to the benign lesions. Elastography having the same concept using the ultrasound machines, giving force to the lesions and to see how it moves, how it displays, and measure this displacement or movement, that to estimate it is stiffness. It is additional feature or additional technique to ultrasound, measure the lesion firmness or stiffness or deformations relative to background of breast tissue after applying a force. Strain, it means tissue compression and motion. Okay. As you mentioned, there are two techniques. And with either technique, acoustic information regarding lesion stiffness is converted into black and white or color scaled image, superimposed on top of beamoid image. And if you look here for this image, I like it. I love it. I found it in the literature and I love it. You see, if you imagine this is the breast and here the lesions, by applying force here, the tissue, all tissue, definitely it will move. The breast tissue as well as the lesion inside the breast tissue. What is the role of elastography? So here, how it can help us in evaluation of breast lesions and when we should use it.
Elastography, it means the malignant goes with a stiff lesion. Benign is less stiff, and graded from 1 to 5.
How it is helpful? Before the interpretation. Before interpretation,
it helps in like mass with a heavy posterior shadowing. On elastography, it demonstrates the whole margin of the lesion.
Okay. Generally, ultrasound is good modality with relatively good sensitivity, but lower specificity. So one of the methods that improve ultrasound specificity is elastography. Usually is recommended to be used for equivocal lesions. You see, if the lesions is suspicious, regardless of elastography, has to be biopsied. If it is simple cyst, no need to do elastography. Typically benign, that means is benign lesions. But for equivocal lesions like BIRAT 3 and BIRAT 4A, you want to, you don't like to follow lesion for 6 months, and then after that you find no need for this follow-up, or the lesion is suspicious, you have to upgrade it to BIRAT 4, or you have to downgrade it to BIRAT 2, and the same for BIRAT 4A. You don't like to do interventions for benign lesions, and at the same time you want to maintain or to enhance cancer detections. So for equivocal lesions, we need to use elastography to help us to either upgrade or downgrade lesions. And it really substantially improve the capability of ultrasound differentiating malignant from benign lesions. And because of distinction between soft and hard lesions provided by elastography, the clinician can direct the biopsy needle to the more suspicious component within a particular breast lesions. Okay, it can decide which part of the lesion is more suspicious that they can take biopsy from that lesions. And as you mentioned, elastography features is stiffness, and the more stiff, the more suspicious or more malignant, and the softer usually are benign lesion with some little overlap. And there are also other features for interpretations of the elastography regarding strain ratio, size ratio, shape, homogeneity, and as you mentioned, the maximum stiffness. Okay. If you look for this image, if you look for the grayscale, you can see there might be a lesion here. Many times while scanning the breast, we have been faced by something like that. Is it a real lesion? Is it not a real lesion? Is it a suspicious lesion? It is not very sharply demarcated, not clearly defined, a true lesion with true boundaries. But by activate the elastography, you see, you can see here this. This is a shear wave elastography, demonstrate a non-homogeneous area, okay, large area of hard lesions in a case of malignancy. So in this case, definitely elastography helping us. This, if you look, this is a circumscribed lesions, is homogeneous, but not very typical of fibroadenoma. Not very typical, okay, but reported or classified as BIRA 3. For me, I don't know, but I'll not put it 3, I'll put it at least 4A. By putting, okay, by activating a shear wave elastography, the lesion itself is not stiff, but the surrounding parenchyma demonstrate stiffness. For that, biopsy performed and revealed invasive ductal carcinoma. So in this type of equivocal lesions, elastography is really helpful. And regarding elastography, there is one commonest technique used, which is strain or static elastography, and the other one is the shear wave elastography. The strain elastography, for which they use external force. How we use the external force? This is a transducer, okay, and the operator doing ultrasound using a manual compression, okay, giving compression to the on the transducer, okay, and that is why it will be operator dependent. See, because you might give more pressure, give less pressure, and it should be an appropriate degree of compression. Otherwise, it will not give a favorable result. Some, they mention that it has to be minimal surface pressure. Others, they said if it is also very minimal, it might not give an optimum result. So it has to be optimized. And this is subjective, see? It can differ from one operator to another. It is not like in the B mode, the compression needed in the B mode image. Flattening of the structures like in the B mode might result in loss, complete loss of signal in E mode. Okay, but so it depends. And that is why some of the machines or manufacturers, they rely on the cardiac and respiratory motion rather than the external force compression, manual compression by the operator. And generally strain elastography giving a qualitative informations, okay? In general, giving us a qualitative, the measuring the deformability of a lesions or stiffness, estimating the stiffness of the lesion either in black and white or in color-coded image. But there is one method of measuring the ratio of the lesion's stiffness to the stiffness of the adjacent normal fibroglandular parenchyma, giving a ratio. They call it strain ratio, and in this case it will be a semi-quantitative method. And generally benign lesion have lower ratio comparison to malignant one. Here, this is the transducer. While applying the pressures, okay, the benign lesions giving more compressibility, more strainable, or more deformity, while the malignant one is not. Okay. What about these lesions? Here, this is strain elastography, compressing the lesions. We are compressing these lesions. What is the result? What about these lesions? How we can read it? How we can
almost hard, totally hard lesion.
Abir?
Yes.
Excellent, well done.
According to the color map.
Yes. The lesion, not only the lesion and the surrounding parenchyma, because the lesion on the elastography image is larger than the gray mode image.
Yes.
Okay, that is why the lesion is complete. The whole lesion is hard as well as the surrounding parenchyma. So this is scale. It will be scale the maximum stiffness. It will be grade or scale 5. Scale 5. You see, does not show any deformability or stiffness, I mean it is stiff lesions as well as surrounding parenchyma. This is the quantitative or semi-quantitative strain ratio. You see, they measure it, the elasticity of the lesion as well as elasticity of the fat far from the lesions in a normal tissue, and the ratio, if it is high, it will be malignant, and if it is benign lesion will give a mild or a small ratio. Also, they can use the size of the lesions in both B mode as well as in elastography. And in this case, what is the difference between the two? In this case, in the elastography, the lesion is
increase in size,
larger, and even the shape of the lesion is different, and textures and everything. So this is
malignant.
A suspicious, this usually stiff lesion, while seen usually is malignancy, and with a benign lesion usually the same size or even less. Okay, same shape and same size. Okay, and in combined O2 correlation methods of strain elastography, the amount of lesion deformability or elasticity of the lesion relative to the surrounding normal tissue displayed in color-coded scales from 1 to 5. Usually the softest, okay, tissue, it means that the greatest strain is red, while the hardest no strain is blue, and the average strain is green, which is green usually the tissue having the average strain. For score 1 or scale 1, okay, which is usually represent benign lesions, there is no signal, elastography signals the lesions same as the surrounding parenchyma. The entire hypoechoic area is soft, okay? There is nothing seen, okay? Having green, same as the surrounding normal breast tissue, no signal. While in scale 2, the majority or predominantly is green, like the normal tissue, but few areas, okay, randomly distributed, seen here as blue or heart, representing heart, giving what is called the mosaic appearance. And from here, they start to say most of the lesions in these are benign. That is why they consider it as a probably benign lesion, not like one is benign, but 2 is a probably benign lesions. Okay, when we go for score 3, you will see most of the center of the lesions, okay, is hard. The central portion is hard, while the peripheral portion of the lesion, as you see here in the in this image, you see it is only central, and the peripheral is free, is not the same. It is demonstrating average strain, green, like the normal breast tissue, and this is scale 3. And how we could know this is part of the lesions? If it is a lesion is hard but smaller than the gray scale, that means it is periphery, is not hard. This is 3, and this is usually they consider it as equivocal. Okay, the cut short for benign versus malignant, it is an equivocal. It depends. See, you might proceed for biopsy for the BIRAT for the scale 3, while scale 4 is suspicious, you see, and the lesion, the whole lesion is hard, but usually equal to the gray scale. But when it is larger than gray scales, even the surrounding parenchyma is also hard, you see, and this is highly suggestive of malignancy, like BIRAT. BIRAT 4 are suggestive of malignancy or suspicious for malignancy, and BIRAT 5 is highly suggestive of malignancy. And we'll see later in an interpretation how to use it to upgrade and downgrade the lesions. If it is BIRAT 3, and we find the elastography, which is scale to upgrade the lesion and downgrading the lesions. And if you look here for this, you have blue, green, and red artifact. Blue, green, and red. This is a typical or specific, okay, a specific pattern seen with a simple cyst. Okay, it is like the posterior enhancement and edge shadowing of grayscale artifacts of a simple cyst. But also in the white and black image, you will see the bull's eye, typical bull's eye. The lesion is smaller than grayscale and demonstrate this typical appearance of bull's eye of a cyst. Classic cyst appearance in the E mode. Bull's eye within the cyst, and as well as posterior to the cyst or distal to the cyst, you will find this train enhancement. You see, this is typical of a cyst. And this we have seen earlier. This is the blue, green, and red artifacts, BGR, okay, but not always. You might see it, you see, like this. This is also cyst, having softest red color, you see, in, is it strain or shear wave elastography? So here,
shear wave elastography.
this shear wave, how come?
Yeah.
No, no, it is not a shear wave. Why? Why it is not a shear wave? This is strain elastography. I'll let you know why. Look, it is red. It is red, complete red color. Okay. This lesion is hard. And this lesion is hard. And both are strain elastography. What is the difference between the two? What is the difference? In this case, they use the blue color.
Reversal of the color map.
Blue, they reverse, they switch the map. The color map is being switched. But if you look here, this Hitachi and this is Semin. So elastography image is encoded in color or grayscale depending on the device used. And we have to be aware about this. And they can switch the map between blue and red for the hard lesions in strain elastography. However, cannot be switched for shear wave elastogram. Shear wave hard is always red. And this lesion is cyst and appear as red, completely red. And here, this is the hard is blue and red is soft. So definitely this is not shear wave. Is it clear, Suhair?
No.
ها؟
ما واضح والله. يعني انا يعني الكلر كود كيف يعني اعمل له سويتش ما فهمت صراحه كده.
Not you. Okay? You will find the machine. It depends. This Hitachi machine, they have the hard as blue and soft is red. Hitachi. And this machine is Semin. They use the hard is red and the blue is soft. You got my point?
Yes.
You will look for the machine, how they used the color map. And from machine to machine, the strain color map is different. Okay?
Okay.
But for elastography, for the shear wave, it is not. They are not everywhere in the world, okay? They are using the red in a shear wave to reflect for the hard lesions or stiff lesions. If you have seen red, okay, and is not stiff, that means this is not a shear wave elastography.
Yes.
You got the point, okay?
Yeah.
Okay. What is a shear wave elastography? We said the strain is static elastography and is operator dependent because depend on using pressure or compression by the transducer, you see, and it's relatively subjective. But the shear wave elastography, it doesn't use external force. It uses an internal force from the transducers, you see. High intensity ultrasound pulse. If you look as if you look for this, okay, water, look for this drop of water. Don't see the vertical effect down. Look how this transversely moving ripples of water as effect of this drop of water. Can you imagine this? This drop of water result in these ripples, okay, of water moving transversely. This is the same as the shear wave elastography. Automatic acoustic radiation force or high intensity ultrasound pulse produced by or generated by the transducer when you activate the E mode. You just activate the bottom of the E mode in the machine, then the transducer will send high intensity ultrasound pulse. This high intensity ultrasound pulse, when reaches the tissue, result in transverse oriented shear waves. You see, moving transversely like that, ripples of water. The movement of these waves, okay, depend on the tissues. The faster the movement, the hardest the tissue, the more malignant. And then the ultrasound measure the speed of these horizontal waves. That is why it is a quantitative elasticity parameters. The shear wave is a quantitative. And the measurement of these, okay, parameters in a meter per second or in a kilopascals, a unit of the pressures. And you will see here number. When you have seen numbers in the color map, that means you are dealing with the shear wave elastography, not dealing with strenuous elastography. You see? The quantitative elastography is the shear wave elastography. You will see here the kilopascal. Okay, this is, and you will see here the red with the highest markers, with the highest kilopascal. And we said that the measurements or the traveling the fastest or the highest in a hardest. It means hardest tissue. It means more suspicious tissue, more stiff. You got the point now. So you will see always red with, okay, with highest number of kilopascal. And generally the lower number are for soft lesions and higher for stiff, and they used in general number of 80 the cut short between the two, but sometimes they decrease it. Still there are many studies decrease it to 20 like that, you see, but you can take it as a whole. Okay, so still when you look for this image, you can read this lesion is red, like in the strain image, having a qualitative measurements for the color map without measuring exactly the kilopascal. Just by looking for the color map, you can get also a qualitative measurement or qualitative information for the shear wave elastography. Is it clear?
Yes.
Okay, good. Since it is clear, there are two examples here. Okay, tell me about these examples. For this one, is it strain or a shear wave elastography? So here, the second one, it will be for Abir, but the first one for you, Suhair.
Yes, this is represent
Is it strain or shear wave elastography? What do you think? What do you think? Okay, we can coming back to which is evaluate the lesion. Evaluate the lesion. How you are going to evaluate?
Shear wave elastography.
Excellent, well done. Why it is shear wave?
Because this is represent in gray scale, it's a suspicious lesion.
Suspicious. And in the elastography?
In the elastography, representing not a red. So this is a blue, and blue represent hard component of the lesion. So it is shear wave elastography.
You got a what? Is it soft? Is it a soft?
No, قلت إنه هي عشان hard يعني not red.
Yeah, but you have mixed. You have mix of yellow and red. Can you go here? Look for the yellow is above 100. The yellow is above 100.
Yes.
And green is borderline. You
yes.
see? Only the blue is soft.
It's hard.
The green is borderline and the yellow is hard, and the red is the stiffest.
Stiff, yes, hard.
Here you have stiff lesions, and these more stiffest part, it is heterogeneous and larger than here. The desmoplastic reaction we have seen in gray scale is included in elastography here. That is why, since it's suspicious findings, it looks it's going more with a shear wave elastography. Excellent. So this is shear wave. Abir, what about the other one? How elastography?
The bottom lesion in the gray scale, it showed complex cystic mass with posterior acoustic enhancement.
Excellent. Well done.
With
how elastography help us? How elastography help us?
This shear wave elastography showed that
why you say the shear wave? Why you say the shear
lesion is totally soft, and the surrounding.
Why
in
you
the
said
barcode in the image there is numbers, and it's not clear. But I think there is
excellent. There are numbers. There are numbers. Since there are numbers in the color map, so we are dealing with a shear wave. Excellent. Well done. So we are dealing with a shear wave. That means this color. That means this color represent. The blue color here represent.
Soft tissue, even the surrounding tissue is soft, totally soft.
The complete soft. So the nodule is this is
presenting green color. I think borderline.
It is blue. It is soft.
Okay.
It is soft. Even the nodule is completely soft. So that means this most likely it will be in specific secretion or benign lesions. You see? But why here there is no signal? Why here there is no signal? There is signal void here.
Because it's a cystic fluid, I think. I'm not sure, but it's the content of the cyst itself.
But we have seen a cyst up giving pulse eye and seeing a red and this and that. Why here it is signal void?
I don't know.
Yes, you don't know, because fluid does not propagate the shear waves. Okay?
Okay.
the cyst, it will give signal void in a shear wave, unlike in strain. Okay, and your case is a complex cyst with adherent debris. You see, this is, they found it as adherent debris only. The elastography downgrade the lesions from being to be suspicious. Okay, is only
Dr. Rabab, regarding this case, I could see a small tiny area in the wall of the cyst. Its color is green or light green. Should I take it or I have to neglect it because it is so tiny?
No, they consider it soft. Generally, because the predominantly is just the blue, you see. So they consider it, and they found it just a complex cyst. This from the literature.
Okay, thank you, Dr. Rabab.
And your case.
Okay, complete.
Complete what?
لا تمي كلامك أنا أديك سؤالي بعد.
Okay, regarding your case, Suhair, you see this is the lesion is only in gray scale is 0.6 by 0.4 in distinct hypoechoic heterogeneous mass. In a shear wave, you see demonstrate stiff mass indicated by red and yellow color, because we mentioned that the yellow color in shear wave is also stiff, but the red color is the stiffest, you see, and it appears larger than gray scale. The final pathological evaluation was 1.6 by 1.6 invasive lobular carcinoma. So the more precisable size is in a shear wave more accurate than in the gray scale. Okay, look for the lesions in the gray scale and in the biopsy result. Following more, the elastography. And as we mentioned, your case, the complex cyst, and this is definitely borderline. This is by RAT4A. So here is the shear wave elastography helping us in downgrading the lesions. ايوه تفضلي يا مدينة.
طيب البلو جرين ريد ستاين اللي كانت في السيست معناتها دي كانت في سترين قبل لما عملنا السكيلز حقت الليجنز قلنا
أيوة
في السيست.
Yes, the previous cyst it was strain. Yes, those who were strain elastography.
يعني sign دي بتكون في السترين طوالي.
This way, yes, in a shear wave they said that in a shear wave the fluid does not propagate a shear wave.
Okay.
And it appear as it is found in the literature, the cyst in a shear wave giving a signal void. Okay. But in strain either be soft, okay, homogeneous to soft, either blue or red according to the color map, or in black and white give the typical pulse eye and enhance posterior elastic shadow or elastic signal. Okay. And in the color coded give the blue, green, red sign.
Okay.
Let us see to make sure. Yes, blue, green, red. Yes, blue, green, red. Big BGR. You see the BGR sign. These all are strain. Here, this is the strain. In strain, this is classic, the bull's eye and apparent strain enhancement distal. This one like posterior enhancement, same as posterior enhancement and smaller. And here the BGR, and here giving complete soft. These all are strains. But in the shear wave, it's usually signal void as they mentioned. Okay.
Nice. Okay, tamam.
دكتور رباب معلش عندي سؤال في الكيس اللي
تفضل.
فاتت حقت دكتور سهير. أنا كيف أقدر أتأكد إنه يعني ما فهمت النقطة ليه أنت كنت بتقولي إنه لازم دي تكون شير ويف، يعني الكيس الأولى بتاعت سهير.
This one or
كيف
the
أقدر
previous? This one?
this one أيوة الكيس
one?
الأبف. أيوة
Yes,
كيف أقدر
here I suspect to be a shear wave because I could see the lesion larger. First of all, the lesion here is suspicious in the gray
أيوة.
scale. And I have seen the lesion larger, okay, than in elastography than in the gray scale. So, since I have seen the lesion larger, more heterogeneous and different in shape. Look here, the lesion, look as if it is rounded. Here, it is more irregular and transversely oriented rather than. There is a lot of difference, which is going with more suspicious lesions, more malignant. So I expect to be stiff, and since the stiffness is red, blue, is yellow and red, that going mostly with probably mostly with the shear waves because in the strain is not a yellow. If you look here, look for the color here. Mostly green, blue, green, these colors. Okay, but here, look here, red, then yellow, then green, then the blue. Okay, and even the green is borderline. The green here is borderline. It is around 70 to 80. Okay, and the yellow is above 100. That is why I suspect this is more toward the shear waves. Okay, that is why I'm trying to analyze, make use of the information we studied together. Okay, but it is not either you might find something, you see, here, the color map, it might reflect for you what is going on.
Okay.
Okay, hint. Take this one.
Okay. So this a grayscale and
tell me the difference between the two.
Okay. The first case on the left, type in the grayscale, there is a high.
Sorry, you said you have two studies. You have two image. Yes.
Yes.
Two lesions. We have two lesions here.
Yes.
So you are talking about which one?
First, on the left side of the screen, the longitudinal one. Each image beside each other.
Okay, which one?
Okay, so there is a hypoechoic region.
Before there is a hypo, you are talking about which type of elastography?
Shear wave elastography, as the map is with numbers, with kilopascals. So
where is the map for this? You are talking about this or this one?
Okay, this have a separate map. Okay.
Or this?
Yes, this one. I didn't see the map. Okay. So this is strain.
Excellent, well done. Why it is strain?
The heart is blue, and always the shear waves, the heart is red.
Strain? Well done.
Yeah, because in the map,
the heart is blue. Yeah, here the heart is blue. That means strain. Okay, excellent.
Okay, so
Excellent.
it shows,
Excellent.
it shows
Well done. Hard is blue. That means we are dealing with straight.
a hypoechoic lesion that proves to be hard with the strain elastography.
Excellent.
Okay.
Excellent. Excellent. Well done. Okay.
In the other one is the shear wave. It is with numbers and kilopascals. The most malignant or the most suspicious is red, 144, and the lesion is blue. It's a hypoechoic lesion, irregular.
Is ISO. This is isoechoic lobulated lesions.
Yes, isoechoic lobulated.
With
And
posterior enhancement.
Yes. And it is blue.
Completely blue, like the surrounding printing.
Okay. So it's a benign lesion.
It's soft, yes. So that is why I brought this. Both are fibroadenoma. But this fibroadenoma is hard, while this fibroadenoma is soft. You see? Both are a fibroadenoma. The mean stiffness here, 30, only 30 kilopascal, okay? Okay, now we complete the elastography. Is it clear?
Yes.
Okay. So, still we are talking about the ultrasound techniques or the modern ultrasound facilities, including harmonic imaging. So what is harmonic imaging? And the transducer, okay, potentially can potentially provide higher image quality than those with conventional imaging by filtering the harmonic frequencies, okay, retaining from the tissue, selecting the higher frequencies to give the image. So increasing the signal to noise ratio. So this can decrease many artifacts, reverberation, speckles, and so forth, and as well as improving the lateral resolutions and contrast resolutions. As you have seen in this case, this a lady, 58-year-old or 56, having remote history of left breast cancer, presented with mammographic 8 millimeter mass. And the same location on ultrasound, barely seen isoechoic lesion here. We are not sure, so it's questionable. We cannot be sure that it is a fat lobule or a true lesions. But by using harmonics, you see, imaging, definitely it provides better image, improve the specificity, the sensitivity, as well as the specificity, the conspicuity of the lesion first, okay, and then characterizations of the lesions, and ultrasound guided biopsy performed, proven to be grade 2 DCIS. Okay, so it's really helpful. And this is the image, which one with harmonics and which one is conventional ultrasound. Huh? What do you expect?
The A is the harmonic.
Excellent. Why?
The resolution of the image is better, and even the posterior characteristics of the lesion, the enhancement is better.
Yes, the reverberation the reverberation artifacts, you see, the low frequency reverberation artifact in the cyst eliminated, and the borders of the lesion is sharply demarcated, as well as the speckles artifacts in the image. So it reduces artifactual echoes, okay, including the reverberation internal echoes or superficial reverberation echoes inside the cyst. Okay, but we have to be cautious while using harmonics. Why? We don't like, okay, to eliminate internal echoes within a soft tissue masses and to read it as a cyst. This is one issue. Also, if you look here, what is the difference between the posterior aspect of the image in harmonics and in the image without harmonics?
The enhancement is more in the harmonics, the posterior enhancement.
I'm not talking about posterior structure.
No, not seen here.
Yes. Why? What do you think? We said is selecting the higher frequencies, that it will be more superficial. That means the deeper structures will not be much evaluated by harmonics. When we use the harmonics, we could not see the deep part of the breast. So we have to be cautious to use the harmonics and then to take it off, turn it off, turn it on, and take it off to evaluate the whole studies. Okay. Regarding spatial compounding and speckle reductions. What is spatial compounding? If you look here, this is a conventional ultrasound transducer. And this is the spatial compounding. What do you think the difference between the two? In conventional standard ultrasound, traditionally send and receive ultrasound signal in a single direction perpendicular to the long axis of the transducer, like this. But the spatial compounding is electronic beam steering, is a technology that acquire multiple frame from different steering angles and combine this image. So it utilizes electronic beam steering, acquire multiple images from different angles while the transducer in static, okay, positions. These images not because we are moving the transducer. In the same transducer, the transducer itself having the capability of sending and receiving different frames, imaging frames, okay, or multiple imaging frame from different angles, then a single composite image, okay, in a real time obtained by averaging these frames. As a result of this, canceled the artifacts. The most important of this process is canceling the artifact to become less apparent. So it will enhance the normal or real structure echoes, okay, but reduce the artifacts. By this, definitely it will improve the conspicuity of the image. It will enhance the margin definitions of the lesions, okay, especially the lateral and posterior margin of the lesions, including the speculations and echogenic halo and these things, you see, and lateral borders, as well as improve visualization of microcalcification and architectural distortions. And also reducing artifactual echoes like speckles and other spurious noises. However, not only that, even the beneficial artifacts like posterior enhancement and acoustic shadowing characteristic of the lesions can also be reduced by spatial compounding. So we have to be cautious, okay, to use it also on and off to characterize lesions. And the artifacts become less apparent and true structures are better visualized, so it will reduce the noise and speckles and improve resolution in the center of the image. These are two examples. Look for these lesions here and the lesion here, and look for this lesion and see it here. Which one with spatial compounding and which one without? Huh? Which image with spatial compounding?
Image C and F are with spatial compounding.
Abir, which
Yeah.
one? Which one?
Image C and image F.
Excellent. Why? Why?
Because I could see the boundaries of the lesion. In image
Excellent.
E, the posterior feature of the lesion couldn't be identified,
Yes.
while in
Yes.
image F, I could see the posterior feature of the lesion.
Excellent. Yes. First of all, this is more grainy. These images are more grainy. You see, the whole image is more grainy, more speckles being eliminated or cancelled in this image. This without a lot of artifact. Even the posterior shadowing is almost disappeared, and the margins here are much better visualized than in this image. So these are with spatial compounding. The margin confidently interpreted with spatial compounding. However, the posterior feature will be less apparent. So we have to use it to turn it on and off. Okay. What about this lesion? What about these lesions? Yeah, these two images. Which one with spatial compounding and which one without?
I think image B is a spatial compound.
Which one?
B.
Which one is less noisy? Which one without the speckles? Remove the speckles, delineate the margins, look for the cyst margins. In which image the margin much well visualized, smoothly.
I think A is more smooth outlines.
So the one with spatial compounding, it will be the less artifactual image. And if you look for the posterior enhancement, see the posterior enhancement, how it appear here, and look for the posterior enhancement here, very faint. So A, utilize compounding, and B, without.
I noticed that the background is more cancelled or less in B. So I think B is the using pink compound or so.
No.
The posterior structures are neglected.
Which image is grainy? No, the whole image, the whole ultrasound image. Which
B is
one
grainy.
showing speckles? Which
B.
one give
B.
So we said that spatial compounding remove artifacts, remove speckles, include all artifacts. خلاص remove by including the posterior shadowing and posterior enhancement. And if you compare the cyst here, which image demonstrate more posterior enhancement? The posterior enhancement with more appreciable and larger in B, yes?
Yes.
So it reduced in A. So the image with special compound is A.
Yes.
Okay?
Okay.
So it give clean margin without reverberation, but reduce the posterior enhancement characteristic of a cyst. This is another look how this is noisy image, and this with compounding. You see, remove the speckles. Okay, increase resolution, eliminate artifact, and eliminate shadowing. Even look here, look for this area. You don't know what is going on. You see here, the image is much clearer.
Yeah.
And look for the border of the lesions here and in the other image. And look for this one. Look for the lesion here and look for the lesion. Look for the whole image, how it is grainy here.
Yeah.
And
yes.
how it is moving in this
Yes.
special compounding. Okay.
Yes.
What about the speckle reductions? The speckle reductions, it is also a real-time post-processing technique. Okay, what is the speckles? We described in the previous image, we said the speckles are artifacts. Which image having the speckles in this, A or B? Which one demonstrates speckles artifacts?
Image A
Image
more
A.
speckles.
Image A is grainy.
Image A.
Speckles is a granular appearance. Okay, it's a granular appearance. Otherwise, the fat should be homogeneous. Okay, it is generated by microstructures showing this grainy appearance. Okay, it can affect the contrast and reduce visibility of the lesions. As you have seen here, you might say this like this, like this. It will be difficult to characterize or to pick up lesions, not like in this image. So the speckles will affect the interpretation of the image, will affect the visualization of the lesion. It will mask small differences in the level of gray. Okay. Speckle reduction is a real-time post-processing technique. This algorithm provides significant reductions in speckles or result in smoothing of the regions, and it enhances the contrast resolutions by increasing signal to noise ratio, and then improve the margin definitions. Okay, so the lesions margin, it will be very clear with speckle reductions. Improve depictions of internal structures of the solid lesions, as well as micro calcifications. It can be used simultaneously with special compounding, or it is a complementary. It can be complementary to special compounding and can be used simultaneously. Okay, in this image, as you mentioned, this is with speckles, and this be using the speckle reduction technique. Okay, and for this, again, look for the image here. How it is noisy, how it is grainy with the speckles, and when they remove the speckles, okay, with the speckle reductions, look for the image how it looks. So the speckle reduction does not eliminate any information. Diagnostic criteria preserved, unlike in spatial compounding. Okay. However, result in significant reduction in speckles, smoothing of the region while maintaining or enhance the edge or border of a lesions. Huh? Do you have a question? Okay. One technique is speed of sound imaging. What is the speed of sounding? As you know, the speed of ultrasound or the sound variable according to the tissue of the body. You agree? It varies. Yes. It varies according to the tissue type.
Yes.
And it is slower in fat than in a dense breast. It is about 1430 to 1470 meter per second for the fat, while it is faster for the dense breast. Conventional ultrasound machine, they have fixed uniform speed for all tissue, 1540, 1054 meter per second for all tissue, travel throughout the body. So this definitely will affect structures like breast, having variable tissues, fat or dense or mixed, and definitely will clearly impact the resolution of the image. So to correct this problem, the development of modern ultrasound machines, they optimize, okay, they have a facility to optimize the transducer according to the tissue component, whatever the breast is fatty, mixed, or dense breast. So by optimizing the transducer speed, okay, then it will improve the lateral resolution definitely, better characterization of tissue interface, delineate lesion margins better, and definitely it will be useful to identify subtle hypoechoic lesions surrounded by a fatty breast, like in harmonics, as well as picking of microcalcification. Let us see examples here. This two image. What do you think? Which one with corrected speed and which one is with a conventional speed? Which one is more, the margin of the lesion more clear? And
the right one.
The right.
The spicules is the right. Definitely the better resolutions in the right. Look for the lesions, how the margins, how the spicules could be appreciable, okay? Not like this one. In this image, okay, generated with a conventional transducer, having the uniform speed, 1540. But this one use the new machines with corrected speed of sound for breast tissue. It gives nice, very accurate, high resolution image. Okay, good delineations of lesion borders and resolution even of the fine spicules. Okay, almost we went through the ultrasound modern facilities, and let us go for next step. What are the ultrasound advantages? As you know, there are many advantages. The most important, non-ionizing, accessibility of ultrasound, relatively low cost, quick, unique opportunity for real-time for guidance of needle biopsy, easy approach. If we find a lesion, easy to be biopsied using the ultrasound, and so forth. There are many advantages of ultrasound. What are the disadvantages of ultrasound?
Operator dependent, depends on the skill of the operator.
Excellent. You mentioned the most important. So breast ultrasound, we can mention limitations first, then go for the most important disadvantages. There are limitations for ultrasound that provide less anatomic details than breast MRI, does not replace a mammography. The study quality is limited by huge breast, extremely dense glandular breast. If the patients in pain, I mean, having inflammatory conditions or many cancer might not visible on ultrasound, result in negative, false negative results, and high false positive ultrasound results in a lot of biopsies, okay, turned out to be non-cancerous lesions. Okay. Can you tell me the difference between these lesions? What is the difference between the two lesions?
I think the angle.
Who is talking?
Suhair.
What is the angle?
The lesion on the left one, it is more perpendicular, and on the right one, it is obliquely, I think.
Okay. Tell me the characters of the lesion. Grade each lesion. If classify each lesion according to Byrat's.
On the left one, it is microlobulated, partially indistinct margin, representing 4B.
Which one?
On the left one.
This one?
No.
This one?
Yes. Partially indistinct lesion on the right, on the lateral side. Microlobulated.
Where is the microlobulation?
It has more than lobule, يعني في والله microlobulated, sorry.
What about this one?
This irregular margin, microlobulated. And
this one is microlobulated, angulated, indistinct.
Is angular margin, yes.
And even here, fine spicules can be visualized. This is
yes.
almost Byrat
5.
Byrat 5. You will give this Byrat
4B.
It's okay. Accept it. Accept it. 4B, 4A. Yes. Someone he might say 3. It is mostly circumscribed. Yes. Here might be an angular border. Here maybe this indistinct like this. So yes. But at least not the same grade. You will not grade it at the same. If I'll tell you this is the same lesions, this one is this one. What does it mean? What does it mean?
أنا بخط على الأنجل غايته يعني دي أنجل مختلفة.
If I'll tell you this lesion is the same as this lesion.
Yes, difference in the angle, I think.
What does it mean the difference in the angle?
يعني انا خدت البروب كده خدته يعني بيربنديكولر ولما
Yes, yeah, so
كده خدته
so
هناك بزاوية تانية.
okay, okay. So you mean the scanning technique of the lesions.
Yes.
If I
The image in the left is less grainy.
okay, this done by one operator and this one performed by another operator.
Same
So,
machine.
what does it mean? Same machine.
Skills different.
Same setting. Yes. Hint mentioned the major disadvantage of ultrasound is
Operator dependent.
operator dependence. You see?
Yes.
So this one less expert than this one. Mammography, suspicious lesion. Evaluated by less expert, okay, ultrasound technologist obtaining this lesion. If you give it highest grade, you will give it 4B. But when rescanned by the senior radiologist, sweeping throughout the margins of the lesions, look how the lesion is suspicious, concordant with mammography findings. Okay, when is breast ultrasound contraindicated? Any contraindication for ultrasound? Can you imagine a contraindication when?
In case the skin overlying the breast is extremely ulcerated or
No, we have done a lot of ultrasound
in case of
for
fungating
fungating
tumors
mass,
or
for inflammatory process. Yeah, in fungating, we have done a lot of cases of fungating tumors. With ultrasound. According to the previous examples, could you imagine when ultrasound breast is contraindicated?
No contraindication.
Ultrasound inherently operator dependent, and breast ultrasound even more so. Thus, a major contraindication would be inadequate operator experience. This is a contraindicator indications for ultrasound, breast ultrasound. You got it? Inadequate operator experience. This is the only contraindication for breast ultrasound. Not related to the patient. It is related to the operator. So, as you know, ultrasound is operator dependent. It depends on the experience of the person performing the ultrasound. It needs meticulous attention to scanning technique and knowledge of various technical options. We describe a lot of technical options and how it can help us for doing breast ultrasound. We have to know a lot of technical options, okay, that can help us to optimize an accurate ultrasound image, okay, to improve both sensitivity and specificity. And generally, the ultrasound breast can be performed by technologist or radiologist. Okay. However, it should be interpreted by the radiologist. But it is preferable for the radiologist to perform breast ultrasound. Why? Because definitely real-time scanning is not like the static image. It provides a lot of opportunity that improve the interpretation skills. Okay, it permit details lesion analysis compared to the static images regarding subtle irregularity, as you have seen in distinct margins. Okay, it will be definitely well appreciated on real time, like you have seen an static one. It will eliminate the artifact, as you have seen. Subtle architectural distortion, you will see definitely on real time. You might not be appreciated on static image. Okay, also it will allow the operator to assess lesion mobility and to make sure you are scanning the clinical, targeting the clinical concern or the patient concerning lesions. Okay, because there is a communications interactive process. It will be, you can better assess the location of the lesion by yourself and the relation of the lesion to the other structures. You will make sure how the lesion is far from the nipple, how the lesions reaching the pectoralis muscle or the chest wall while you are scanning. And as we mentioned, interactive, you can talk to the patients. You make sure, is it tender, not tender, that you are talking about the same lesion. This is the clinical concern or the patient concern. It is the same of the lesions on mammography and the lesion you have seen. You are talking about all these things. It will be provided if you are going yourself and scanning the patient, not just looking at static image in the back system to be reported. And definitely it will be more easy for you to make sure you are talking the same, correlate the what you have seen on ultrasound with what you have seen on mammography and MRI. A capability it will be difficult for the technologist. However, definitely this scenario having a major impact of radiologist involvement by the time factors. Okay, and it will affect the workflow. How to manage this? By the new era of 3D ultrasound. It's helping in these limitations of handheld ultrasounds. This is a handheld ultrasound, and this is the 3D ultrasounds. And obviously here using a high resolution linear transducer with a footprint narrow up to the 5.8 centimeter in width, while in the 3D using a high resolution volumetric linear transducers with a footprint up to 15 centimeters. So it will result in really very fast study, while the handheld is time consuming. Okay, comparing the handheld with automated, also the handheld can be performed by radiologist, sonographer, or mammography technologist, while the automated usually performed by the sonographer or the technologist, with the image saved later for the radiologist to interpreted. Okay, so this will increase radiologist efficiency. And the handheld, as you know, is operator dependent. It needs meticulous attention to scanning technique and good skills and all this, the automated is less operator dependent. And both should be interpreted by a radiologist, while automated ultrasound having ability to depict the entire breast in a single image, the handheld could not depict the entire breast in one image setting, and handheld ultrasound having limited ability to scan the entire breast, especially if it is large, if it is huge, you might miss part of the breast that can result in cancer missing, while the automated breast giving a better imaging of the whole breast and increase the efficiency for cancer detection by almost 100% as compared to mammography alone, and increase reproducibility, which could aid in the follow-up lesions. Handheld ultrasound it's being used usually in diagnostic setting, while the automated usually in a screening setting. This is the image of 3D automated ultrasound of a dense breast, demonstrated multifocal, okay, suspicious masses in a case of invasive cancer. This is a nipple, and look, even shows where the lesions related to the nipple. And here, this is the patient is lying supine, and the technologist doing the 3D, taking almost 3 views. You see, this is at the center, AB view going laterally, taking a view obliquely and going medially and taking another view. When you look here, the nipple at the center, this is the one view, the central part, okay? And when you see the nipple going more medially and larger breast laterally here, this is the lateral view, and this is the medial view, and the same for the contralateral breast. This is for the right and this is for the left breast, and this is the acquired image, okay, in the transverse, the axials, and in the sagittal, as well as in the coronal. This is the breast. You see, these are the 3 planes. The image will be taken in those planes: the sagittal, the axials, coronal, as well as the 3D reconstructions, and all preserved in the system for the radiologist to interpret it. And also they can use the elastography, you see, with the 3D image as shown in these examples. You see, which elastography is used here?
Shear wave elastography.
Yes, this is the shear wave elastography used with the 3D, demonstrate stiff lesions here. You see, this is yellow and this is a stiff or moderately, we can say a moderately stiff lesions. Let us see what is written here. Screening tomosynthesis is not shown. 75-year-old lady. The patient recalled for targeted ultrasound confirmed the presence of small irregular suspicious hypoechoic non-parallel indistinct margin. The 3D combined with elastography demonstrate irregular mass.
ده حضور انا كيزو فاهمه كده فبس بقرا برايه اعمل شنو؟ صح شيلها هنا شيلها هنا احطه وين بالشعر؟ تجد خليه معاك
Beginning from upper corner transverse, and it was an infiltrating ductal carcinoma. Okay. So, in summary, as who's talking? Would you please mute your microphone? Excuse me. Would you please mute your microphone? Okay. In summary, as ultrasound imaging technology advances, new methods offer incremental information over what basic scanning can yield. And almost all of above new techniques are now available in modern ultrasound unit and are optional, and we have to use it. What is the benefit for that of using this new ultrasound technique have been offered in this modern ultrasound machine? Definitely increasing sensitivity as well as specificity of breast ultrasound, and then improving the image quality. So by performing high quality breast ultrasound, definitely will improve breast ultrasound diagnostic accuracy, confidence, and consistency. Will increase patient throughput, will improve cancer detection rate, at the same time will decrease the rate of intervention for benign lesion, especially in the young woman where ultrasound should be the diagnostic tool of choice. However, it should be borne in mind that breast ultrasound is extremely operator dependent. If a system's many image parameters are not optimally modulated, poor image quality can lead to serious misinterpretations, such as mistaken cancer for a cyst. And therefore, it is essential to receive appropriate training and use the appropriate equipment. Automated breast ultrasound system overcome most of these limitations. It scans the whole breast volume and increase the cancer pickup rate by almost 100% as compared to mammography alone. And it the use of the 3D automated ultrasound add additional features to image and is slowly refining benign and malignant characteristics of breast masses. And other areas of future progress include contrast enhanced ultrasound, optoacoustic ultrasound, and AI. And thank you very much. Do you know Jabalain City?
Yes.
Who said yes?
I hear of it much in Nil Al Abyad, I think.
Yes, 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 yes.
Jibna and Fasih is very nice there.
Yes, yes, yeah. It is the last city related to the north. You see, it is location between the north and south.
Yes.
Yeah, it is my city.
Or
it is my village.
Oh,
now it's become a city, but before it was a village. But it is really, yani, very nice. Look how it is green. And there are two mountains. The name is from the mountains. It has two big mountains. And the White Nile running at the south of the city. At the north, not at the south, at the west. At the east is the two mountains, while at the west is the White Nile. You see?
Many petroleum. Okay, thank you for you, Dr. Rabab.
I hope it, it is digestible, or it was digestible topic.
Yes.
Nice topic, interesting.
It is not so hard as you mentioned. خوفتينا ساي أول.
I just prepare you. I just prepare so as not
expectation كانت أكتر من كده، لكن ما شاء الله